Good afternoon. Welcome to today's Grand Rounds. If you could remember to sign the attendance record, we would appreciate that. And also, if you could please fill out the program evaluation before you go today and turn those in. And if you could give us any ideas that you might have in regards to future topics or future speakers that you'd like to hear about. Today, it's my pleasure to introduce Dr. Paul Mulhausen. Dr. Mulhausen is an internist and a fellowship-trained and board-certified geriatrician. He is currently clinical professor of medicine at the University of Iowa, and he directs the Geriatric Evaluation and Management Clinic at the VA in Iowa City. And he's also the co-director of the Geriatric Fellowship program there. He's here today to discuss what I consider a very interesting and important topic, and he's going to discuss fall prevention, its impact and prevention. And please join me in welcoming Dr. Mulhausen.
Thank you, Dr. Hallberg. So, can you all hear me all right with the mic here? Very good. I would like to thank you all for inviting me here. It's a real pleasure to get out and about the state, and I spend a lot of time as a clinician thinking about falls and fall prevention, and I appreciate the opportunity to try to talk to you about it in a little more rigorous, organized fashion. So thank you for having me here today. How many of you are nurses? Okay, good. And physicians? Okay, are there other people from other disciplines here? I see you guys shaking your heads. You're eating though. Like rehab disciplines. Okay, so this is a topic that is truly interprofessional, multidisciplinary, whatever language you like to use, interdisciplinary. And in all honesty, outside of a couple of things that physicians can do, effectiveness is rooted in good teamwork. All right, so I'm glad we have a number of members of the team, because what I hope you will learn from this, and you already may have a sense of this already, this is about teamwork. This is about working together in a holistic fashion to prevent injury to our patients. So that's the title of my talk. I did alter the objectives a little bit than what you will find on the Mary Greeley internet site, but let me go through these objectives with you so that you have a roadmap of what we're going to try to accomplish today. So our first section will just talk about how bad falls are. I think as clinicians, it's easy to lose sight of the impact if you're not literally an orthopedic surgeon or a physical therapist rehabilitating people after they've fallen and injured themselves. So just to help the broader audience appreciate the impact that falls have on older people, we're gonna talk about that impact so that you'll be able to talk with other stakeholders about why we should be thinking about this topic. The second objective I want you to get out of this is to be able to think in terms of multi-factor intervention. And what you will learn as we go, if you don't already know it, is that there are very few pieces that actually, if you do this, people fall less. It takes a puzzle. It's a puzzle. It's a multi-factor puzzle that if you try to put all the pieces back in place, you can demonstrate impact. And that's the notion behind this multi-factor intervention strategies. For medical providers who do a lot of prescribing, a major responsibility that we have is both to try to keep from hurting our patients by prescribing medications that can impact balance and increase fall risk, and take the opportunity to eliminate medications as a risk for falls. And so I do want to spend a slide or two just reviewing, not getting into too much of the detail about medications that impact high fall risk. And then I think lastly, one of the challenges I find as a clinician working with older patients is I feel like I put a lot of energy into this and I'm never quite sure it seems to work. So how many of you work in nursing homes or have a practice that includes a lot of nursing home residents? A few of you. Right, so you know that if you work in that world, you are utterly immersed in this world of people falling all the time. And you feel often like you do a good job and yet they still fall. And so I think it's very useful to look a little bit more closely at the science to help you understand that when you do this right, it does in fact matter. You do in fact have an impact. Okay? So that's what we're going to try to accomplish today. Any questions about that? All right, so let's start with a case. This is out of my own practice this year, in fact. This is just the basics of it. It's an 85-year-old woman whom I met actually in a nursing home after this particular experience. So she was visiting at her daughter's house. She was visiting her daughter. After eating breakfast, she got up, lost her balance, slipped, fell to her right side, and was not able to get up. Her daughter couldn't help her up. They called the ambulance. She was brought to the emergency room and admitted with right-sided hip pain, and I just drew the line here to help you see it. She has a hip fracture right there. This is not a conversation about hip fractures. It's a conversation about falls, but the injury here is a good place to start. So falls are really bad for our older patients. They're common. They have become a public health problem as well as a personal health problem. And what I want to go through is both some national and Iowa data that illustrate just how big this problem has become and that it's likely going to get worse. So in the United States, every 18 seconds, an older adult comes to the emergency room after a fall. And knowing the demographics of an aging population, I think it's useful to know that a third of adults over the age of 65 fall. So with growing elderly population, heavy utilization of healthcare services due to falls, you can see that this is going to be an even larger problem for our state, for us as professionals, and for our country in terms of healthcare financing. These are Iowa data here. All right, this is what happens in Iowa. And this is the most dramatic slide in my mind in terms of highlighting the impact on older adults. And so this is hospitalizations due to falls, or due to an injury due to falls, and you can see that it's a relatively small impact until you get here, 75, and then 85, it just skyrockets. So when you start to look at some of the modest impact of interventional strategies, think about this huge number. And if you can impact this large number in a small way, it actually starts to have meaningful effect at a public health level. In terms of emergency department visits, just another way to look at it, you can see there are lots of little kids falling in the playground, breaking their arm, and then it drops off for those of us in a middle-aged, and then once again starts to really skyrocket for our older patients. Among older adults, falls are the leading cause of injury death, more than car accidents, non-fatal injuries, and hospital admissions for trauma. When it comes to dying from a fall, these are how the data look. So once again, these are Iowa data coming from Iowa hospitals and Iowa death certificates, and you can see here that this has a huge impact on caring for our frail older patients. The last thing to realize is that this has more than an impact just on the injury, the hospitalization, the treatment. This has a huge impact on the life of our patients in that they often this is the seminal event in their loss of independence. So people over 75 who fall are 4 or 5 times as likely to end up in a nursing home with that loss of independence. So that helps you understand some of the health costs, and here are the financial implications of those experiences. So you can see that in the US 10 years ago, the costs exceeded $19 billion, and 8 years from now, the costs are expected to reach about $55 billion for caring for the injuries related to older people falling down. Average Medicare costs are between $9,000 and $13,000 per fall. That's per fall, okay? And then if you look at the costs related to those who are injury, it's around $18,000 per fall related injury. And of course it goes up depending on the severity of the injury and the impact of that injury on function. The message out of this slide is that falling down in old age is very expensive, both to our healthcare system and to our society. So those last 3 or 4 slides were really intended to achieve objective number 1, which was to help you appreciate the impact of falls. And just to summarize, falling in old age has become a major public health problem, both for Iowa and the US as a whole. Falls has a major impact on the health and well-being of our older patients, as illustrated by our case. And third, falls are very expensive, and it's only going to get worse. So we are at the right time and the right place to be talking about this topic in terms of how we can change that trajectory, bend the curve, as they say. All right, so this next part is to talk about the multifactor nature of falls and use that multifactor nature to influence and structure how we approach prevention programs. Okay? Does that make sense? All right, so if you think about falls and when and how they happen, you will find there are essentially these 3 elements. The classic one is, doctor, I tripped over the curb. Okay? Now, that's just part of the story. And I spend a lot of time with young physicians who will tell me there's no medical issue because they tripped over the curb. All right? And my only reflection to them is, well, I trip over the curb all the time. And I don't have a broken hip, and I'm usually not falling with my face on the concrete. There is more to this than just this precipitating environmental factor. Although from a public health perspective, it's very important for us to consider that. And from a personal health perspective, where we might be giving advice on home modification, that first bullet point becomes very important. But it's also important to realize that there are these predisposing host factors, some of them rooted in diseases, which you may or may not be able to ameliorate. Some of it rooted in treatments, which are a huge problem both in institutional settings and also an opportunity. So it's important for us to think about these, to consider avoiding or to minimize the impact. And so those are what I would call the host conditions, and then the medication or treatment conditions that we introduce into the mix. And then there's an interaction among these 2 factors. And you will see the language changing. I grew up with the language of intrinsic factors, which are the host factors, and extrinsic factors, which are the host interacting with the environment. But the language is changing where you'll see more of this predisposing and precipitating if you decide you want to dive into the literature in greater depth. Now this is a very busy slide. There's a lot of information on here. But what I really want you to see is essentially the bullet point list. These are the risk factors, okay, that patients bring to the table in terms of fall risk. The big one you can see, now let me try to describe this slide to you a little bit better. So this would be a risk factor here. Muscle weakness would be our prime risk factor, an example. It's been studied 11 times. Out of the 11 studies, 10 of them found them to be a significant risk factor for falls. If you summarize the risk, it increases the risk fourfold, and this would be the confidence interval. So at best or worst, depending on how you look at it, it has a 1.5 times, increases your risk 1.5 times, and at worst, it increases your risk tenfold. All right, everybody got that? If you want me to reorient one more time, raise your hand. If you don't, you understand the slide. And I've ranked these, this is my own ranking, in terms of their robustness, in terms of our belief that they are in fact a risk factor, and their impact on risk. So muscle weakness would be a primary one, which has shown up quite consistently across studies. A past history of falls is a huge marker. For those of you who spend your time in the clinics, one of the recommendations would be to elicit this risk factor by asking, have you fallen? Because it's not something that our patients routinely divulge or spontaneously report to us. Abnormalities of gait become a major risk factor, increasing the risk by threefold. Again, for those of you who are clinicians, one of the recommendations that comes out of this would be if you think, if someone reports to you that they have fallen, or you elicit a history of falls, that you watch them walk, which I learned my first year as an intern on my neurology, we call that, wasn't a clerkship, rotation, my neurology rotation. Barry Hurwitz said, Paul, get your patients out of bed and watch them walk. And that still holds true in the outpatient arena as well as in the hospital. So here's the list. I won't go into any more detail or expound on it, but these are the list of intrinsic fall risk factors that if you want to try to impact the risk of falls for your patients, needs to somehow be elicited in the evaluation process. Any questions about that? All right. I want to also bring up the topic of vitamin D. So I think there is still some controversy in terms of vitamin D as a risk factor for falls. I think the controversy is slowly disappearing, and I think we're reaching a consensus that vitamin D deficiency is in fact a risk factor for falls, and you're now starting to see formal consensus guidelines that recommend treatment of vitamin D deficiency as a intervention to reduce fall frequency and fall risk. But I want to highlight the controversy so that you understand what it's rooted in. So this particular graph I took straight out of the Institute of Medicine's report on vitamin D recommended daily allowance. So there's a group of clinicians who have said we should be recommending more vitamin D for our patients. And so the Institute of Medicine convened a panel to talk about and think about this particular topic. And they reached a conclusion that there was not enough evidence that vitamin D deficiency increased the risk for falls. Now that I think is worth thinking a little bit more about, because this is what they're rooting their conclusions in. And I know it's very sciencey, but hear me out, because I think it's useful to know, again, where this controversy is rooted. They did something called a meta-regression. And if you look carefully at this graph, this is your risk of falling down, okay? So one would be average risk, and here is your vitamin D level in your blood. This is the research. And what they plotted was different studies that looked at vitamin D level versus fall risk. And if you draw a line averaging all of those observations, this is the line you get. You follow me? Everybody got it? And that line is not far enough from 1. In other words, it's not far enough from a flat line to reach statistical significance. They've drawn the conclusion from these data that there is still controversy about vitamin D deficiency and fall risk. Now here's the counter argument. So here's their argument. This line is not far enough from flat. And that's what you see right here. Relative risk reduction is 0.92. The confidence interval includes 1. Now here's the argument from another group of vitamin D scientists. They say there's a threshold here that happens somewhere around right here. And they draw these two lines. Okay? So they make the argument that if you're up here with a vitamin D level less than 60 nanomoles per milliliter or per liter, that you're at higher risk than a person who's above 60 nanomoles per liter. And the only reason I bring that up is that if you read the Institute of Medicine, they'll say, 800 units of vitamin D. And if you read a variety of other guidelines, they'll say 4,000 units of vitamin D a day. And you may have trouble, as I do, sort of sorting out who's right. And this is essentially how the two groups are making their decisions. So as you think that through. So vitamin D is certainly an evolving risk factor for falls. And I think you're going to see some different recommendations as people sort out its role in risk of falling down. Okay? So those are the intrinsic factors. Those are the things that you might want to look for if you ask the patient, have you fallen in the last 6 months? And they say, yes, I fell 4 months ago and when I was working out in the garden. So then the other side of the coin are these precipitants, these things that people trip over, these things that people fall over. This actually ends up being very important if you're trying to mitigate risk in the hospital, the nursing home, or at a home. So all of these settings ends up that there are modifiable environmental factors that you can think about, you can talk to your patients about, and that you can change to make the environment more friendly for people who have some impaired balance. Okay? Things in the home, just to mention a few: clutter, poor lighting. At an institutional level, nursing homes have been notoriously targeted for having beds that don't necessarily fit the height of the patients, loose carpets, again, poor lighting. In the community setting, Iowa City has done a lot of work to try to make some of their sidewalks have fewer obstacles and fewer barriers to walk on safely. So sidewalks would be a big one. Again, poor lighting, poor rails going up and down stairs. I have a patient who lives in Muscatine and has to go up a hill just to get to his home, and one of the things that we were able to do for him was convince him to put in a side rail so that he could go up and hold on to that as he went up and down the stairs. All right? So very straightforward, common sense issues, but important to bring up in an evaluation and important to try to mitigate. And again, because at the institutional level, many of these things are not going to be things that a medical doctor is going to particularly change. It becomes very important to be working as a team to highlight some of these extrinsic factors and change them for our patients. So intrinsic risk factors, precipitant extrinsic risk factors, and then here's where a huge opportunity lies for the medical community, and that's drugs as fall risk factors. I want to take a little bit of a sidebar. I spent breakfast this morning with a public health PhD person who's thinking of moving to Iowa to be part of the University of Iowa. And she's especially interested in public health interventions to improve fall risk, to minimize fall risk and fall-related injury. And we were talking about what you could do at a public health level. And I believe there's a role for educating patients about the risk for medications on balance and falls. And not because I expect them to suddenly change their pills, but in my mind it creates a fertile environment for a clinician, counselor, physician to be able to say to them, I think we need to change some of your medicines, and have a receptive patient to those kinds of suggestions. And you'll see in a second why I think that ends up being important. So medications are a major part of the problem. One of the risk factors for falls is just taking 4 or more prescription medicines. And I don't know, again, those of you who work in nursing home settings, I think the average number of prescription medications for a nursing home resident in Iowa right now is 9. So getting rid of medications actually ends up being a potentially valuable strategy. It may not be something you'll be able to do with every individual patient, but as a way to practice medicine, it might be a very helpful strategy. Benzodiazepines are also a huge issue. Now, when I trained, I was taught long-acting benzodiazepines are the problem. So it would be Librium, Valium, those medications that spend a lot of time in the central nervous system. It actually ends up epidemiologically that the short-acting and medium-acting benzodiazepines also increase fall risk. So I think you have to be thinking about benzodiazepines in terms of a class and their impact on fall risk. Antidepressants are part of the problem. I think this can be especially valuable in light of some data recently that suggests that antidepressants aren't all that helpful for older people with their first episode of depression. So tricyclic antidepressants are notorious for impacting balance and increasing the risk for falls. And you're not really necessarily mitigating that risk if you switch people to an alternate antidepressant such as an SSRI. These are centrally acting medications that impact balance and increase fall risk. Neuroleptics, and that essentially for me is the antipsychotics, again, notorious for impacting balance, mobility, fluidity of motion. So they are a major risk factor for falling down. Anticonvulsants, I'm a general physician trained in internal medicine, and one of my most memorable cases was a patient I was responsible for where essentially I was overdosing their Dilantin. And they kept falling and falling and falling. And it took a colleague at the university to say, you know, check a Dilantin level, dummy. And so anticonvulsants are a major player here. For those of you who are cardiologists, we're seeing a lot of patients with rhythm disturbances. Type 1A antiarrhythmics are a problem. And then in the hospital setting, diuretics have a particularly unique role at increasing the risk of falling down, because the main reason is that people gotta pee and they get up to go to the bathroom and then they fall. It's been a little bit harder to demonstrate their role in community settings, but in institutional settings, diuretics are clearly contributing to the problem. And just for perspective, around 1 in 10 of the falls in a nursing home does involve an acute drug toxicity. So this is a big issue, and being sensitive and aware of the impact of prescribing on falls actually is a very important responsibility for those of us who are prescribing medications to our older patients. If you put all of these risk factors together, they start to add up. They compound each other. If you have one of those risk factors in modeling that we've just talked about 1 in 3, 1 in 4 will fall. And if you have 4 risk factors, 80% of those people will report a fall in the subsequent year. And if you do some risk modeling and you have weakness and you have an abnormal gait and you take more than 4 medications, if you have all 3 of those, you will fall over the next year. All right? So these things do add up. They compound each other, and they, you can use them to predict risk of falling down. So that's the multi-factor nature of falls, and hopefully you have some sense of that. The next thing I want to move into is how to apply this multifactor nature. And the problem you have is that we work with different populations of older people. And each of these populations has their unique challenges, their unique barriers, unique opportunities. And so if you want to really understand how to impact the risk of falling down, you need to think about these patients in these different settings, all right? So the places that you get, you can find effectiveness literature would be people living in the community, which would be this group, people living in nursing homes, which would be this group, and people in the hospital, which would be this group. And the literature is different for each one of those. So we're going to walk through these little by little, one by one, and just give you a sense of that. So concepts to apply. Identify risk factors, which we've just talked about. Mitigate those risk factors. Do what you can to minimize them. Remove the hazards. Change all those risk factors that you can. That's the multi-factor intervention. Do them one at a time, and we'll talk about that a little bit more. Make sure it's focused on the patient, and make sure that there's a public health focus to it. So those are the concepts that we want to be applying. So now I want to go back to our case, because our case, I think, illustrates some of the challenges that we all face. So this is her med program. So this is an 85-year-old lady living in Iowa who just happens to end up in Iowa City because her daughter is there. And this is the medication opportunity here. So she's on doxepin, which most of you know is a tricyclic antidepressant. It's very sedating, it's highly anticholinergic, and I don't know how many of you are familiar with the Beers list, but it is a drug on the Beers list that is considered to be a medication that should be avoided in older folks. She's also taking 4 milligrams of Ativan at home, at night, to sleep. And if you calculate her benzodiazepine dose in terms of relative benzodiazepine dose, she ends up actually off the scale here. And so her odds of having a risk factor would be increased by 1.5 just by taking this 4 milligrams of lorazepam. Meloxicam is a complicated drug in terms of prescribing with the elderly. I think you could argue that it's okay to use in some circumstances, but at least 2 of the medications that she's on increase her risk for falls and are considered to be, at least at these doses, essentially contraindicated for an 85-year-old lady. All right? Now the problem is she isn't going to give them up. Not for me, not for anybody. And so the challenge we face is both not prescribing them in the first place so that we don't end up in a circumstance where we have to backtrack, and then helping our patients understand that this is about preventing their hip fracture. This is about preventing them from being in a nursing home. This is about preventing their traumatic brain injury. And I don't think our patients, and even some of us, are making those connections. All right. She also has a number of other medical problems. She has chronic pain problem from osteoarthritis. Her vision is poor due to macular degeneration. She says she could walk just fine before she broke her hip. I don't know, but I'm pretty sure that wasn't true. And then the sad part about it is, of course, because she won't change, she falls again. And she's back in the hospital within 5 months. And so right now, those of you who are working so hard to prevent readmissions to hospital recognize she is a high-risk problematic case. And this is how it all interacts together, okay? So all of these multi-factors come together ultimately to create this fall risk. They have a precipitant, and then they fall. All right, so that's just for you to look at. So let's just start out with place by place. And this is falls in the community. Now, what I'm really trying to help you do here is I'm trying to convince you or help you understand this is really worth doing. You can impact falls. So these are standard Cochrane reviews. And what you want to get out of these particular photographs is that this red line is to the left of this blue line. And that means it works. Okay? So this is on falling once for people living in the community. So my practice, an outpatient ambulatory practice, if I take a multi-factor approach, I ask people about falling, I check their gait, I look for risk factors, I try to prevent and mitigate poor prescribing, I actually help prevent falls. Even more importantly, I reduce the frequency with which people fall. So that ends up being very potentially valuable when you think about the broad scope and the volume with which this is taking place. Okay? So doing this in the community works. Here are the numbers. If I do this with 11 people, I prevent a fall at least once. That's what that means. If I do one thing, only one thing, and say, you should go see a physical therapist and get some exercise, if I do that to 16 people, I prevent at least one fall. So that's 15 other people that you can't argue you made a big impact on. But in medicine, these are good numbers. So a number needed to treat of 11, a number needed to treat of 16 to prevent at least one fall ends up being a fairly good number needed to treat, illustrating that it is a potentially valuable intervention and a potentially valuable approach. Okay? So here are the lessons learned, just a series of bullet points. You should do a multi-factor fall risk evaluation, and then you should do the following things based on that evaluation. Get gait training, refer the patient for gait training and training in the use of adaptive equipment and assist devices. Review and modify medications. Get the patient to someone who can help them with an exercise program that includes balance training. Treat postural hypotension. Look for it. Take away medications that cause it. Try to minimize postural hypotension. That's supposed to be hypotension. Help the patient modify environmental hazards and make sure that their cardiac problems, which essentially here are rhythm disturbances, get treated. And then outside of vitamin D and exercise, individual interventions are not consistently effective. So you got to do all that. That's the point of this. You got to do all that. You do all that, and you have an impact. This requires honest-to-God holistic care. All right? If you can only do one or two things, if they have an abnormal gait, refer them to a physical therapist and treat them with vitamin D. Okay? And that's the point of this slide here. So there are two, I think, useful guidelines out there for you to take a look at if you have the time. So one is the U.S. Preventive Services Task Force that says prescribe vitamin D and send them to a physical therapist for exercise. And then the other is the American Geriatric Society recommendations, which include those two, but then make an argument for multi-factor assessment and management. Okay? That includes helping people with cataracts, get them extracted, referring people to home health programs for home hazard modification, and including some education to help them change for themselves, behavior change. Okay? The next section I want to talk about is that patients will resist this. So this has been the big surprise of my career. I'm not sure why. Patients don't want to do this. And the reason they don't want to do this is very interesting. So they view this as a major threat to their autonomy. You're falling, go home, fix up your bathroom, make it a safer place. And what they've just heard you say is, you're falling, you're getting frail, you're getting old, you need to move into a nursing home. That's my editorialization. But they do see this as a threat. So one of the things that you want to keep in mind as you're engaged in this conversation, education, intervention, would be to highlight the positive sides of this. Okay? All right, long-term care. So in long-term care, you're dealing with a group of people, 40% of whom are there just because they fall. All right, so very, very high-risk population. I think 20% of the deaths from falls in Iowa occur to people who have fallen in a long-term care setting. It's also a high liability environment, so if you're providing long-term care, you have to be thinking about falls in terms of preventing liability risk. And there have been 6 studies that have tried multi-factor interventions to mitigate fall risk in nursing homes. And you can see there's a lot of variability in terms of what they did, which is a problem in terms of deciding what you should do yourself. But in general, this application of a number of interventions across a variety of risk factors would be thematic. And then here are the results. Now this is a very busy slide for those who really want to look at it. And I'm going to skip to the next one because this is essentially how I think about it. I'm the medical director for a 100-bed long-term care center in Coralville, Iowa. All right? That's my world. I get it. If we do this, for our residents in this long-term care center, we prevent 60 incident falls per 100 residents per year. Okay? So we'll have 60 fewer falls. And you can say, well, no wonder I can't get a sense that this helps. Even if I do it right, there are 244 falls that they've called me about every day to tell me someone has fallen. And you cannot get a sense that you've made any kind of impact. But the numbers bear out that you do. And when you think about those 400 nursing homes in Iowa that are 100 beds, that's a lot of people that you've reduced 60 falls in each of those facilities, and that all starts to add up. And then I think most importantly is that you reduce the rate of injurious falls. So you have 5 fewer falls a year that a person's going to be seriously hurt. And you don't have really a good sense of how much it costs for you to do that. But if you can build that into your routine care practices, that's how I look at this. Okay? I prevent 5 traumatic brain injuries, maybe 5 hip fractures per year in my little 100-bed nursing home. And from my point of view, that's worth my while to be a champion. Okay, exercise is a little problematic in the nursing home because these people are so frail. My own practice is to incorporate it, get a lot of rehab input. And this bottom bullet point is really where I'm at with this. Multifaceted fall prevention programs can work in the nursing home, but it's not a perfect intervention. Now I want to talk to you about the hospital. So we'll spend maybe 5 minutes on the hospital. So most of you work, how many of you work in the hospital? You're part of the hospital staff. So at least half of you. So this is a big deal because one of the major quality initiatives on the part of CMS is to try to reduce falls in the hospital. And any of you have had patients who have fallen and broken their hip in the hospital, you certainly realize the sinking feeling that you get when that has happened. You feel bad about the experience for your patient. You wonder if you could do a better job. So this ends up being a really important issue. It increases the length of stay. If you fall in the hospital, it costs the hospital another $4,000 in terms of their DRG. And so CMS, I don't think they like the term never event, but they have a major initiative to try to reduce falls. Now I have to admit that I have up until recently been relatively skeptical about impacting the frequency of falls in the hospital, but we're going to just look at a little bit of evidence that says it can be done. And it would be similar to the evidence you have in the nursing home. Well, even if you do it right, you're still going to have a lot of falls. And so to characterize it as a never event is not appropriate. But to characterize it as an opportunity to improve care and prevent injury to some of our patients, there's relevance, okay? So here are the things that are different about the hospital. So one is they're very sick, okay? The second is they have a heavy burden of delirium. And if you want to really look at some exciting research, look at Sharon Inouye's research on delirium prevention and how that intervention designed to prevent delirium reduced the rate of falling. Okay? So helping patients stay cognitively intact during their acute illness actually has a huge payback. The wards are all different, so coming to the med surg ward at my hospital is going to be very different from going to the orthopedic ward or the ENT ward at our hospital. These are complex environments, oxygen cannula with tubing tying you to the wall, IVs tying you to a pole. These become restraining devices, and we know from 20 years ago that restraining devices increase the risk of falling down. The lighting is usually poor, at least it is in the rooms in the hospital where I work, and oftentimes the bed size is not really designed for the patient in the bed. We talked a little bit about diuretics and toileting. 50% of the falls in the hospital in some research has been from trying to go to the bathroom. So toileting takes on a whole unique role in the hospital. And here's the best result research synthesis that I can find. So this was British Medical Journal in 2007. I was at a presentation maybe a month ago where a group of nurses showed similar kinds of systematic analyses that suggested that they can have an impact in the hospital if you do it right. But from my point of view, these are still the best data you have. So you can maybe impact falls, you see that here, reduce it by 20%. When it comes to injuries, it becomes a little more difficult. And when it comes to actually preventing people or reducing the number of fallers, it becomes difficult. But you can impact falls. I'm not sure what the next slide is, so I'm just going to share with you a couple of major points from this literature. One, it has to be multifactorial. To come in and say you've fallen and then get a PT consult and think that's going to solve it isn't going to work. It has to be done as a team. It has to be done with a strategy. So the ward has to have a strategy. We're going to reduce falls. We're going to identify risk. We're going to highlight those who are at risk. We're going to mitigate the risk factors that we find, okay? We're going to institute rehab programs, and we're going to change the environment. And that's not about me walking into a room and taking away their Ativan, even though that has to be part of it. So these have to be institutional responses. And let me go back to Sharon Inouye's work on delirium. She did work at Yale New Haven Hospital that showed that if you take this interprofessional, interdisciplinary, holistic approach to care, you reduce the frequency with people who have delirium, you get them out of the hospital faster, and it saves the hospital money and prevents falls. And if you look carefully at what they did and why that should possibly have worked, one of the major changes they made was they helped people fall asleep without sleeping pills. Okay? So they did that by nurses giving massages, volunteers coming up and playing soothing music and reading books at the bedside, giving people soothing warm drinks to help them fall asleep, rather than they're not falling asleep, call the doctor and get a order for some Benadryl so that they'll go to bed. And that requires a very holistic, interprofessional, coordinated effort. And that's where you get your payback, okay? So it almost has to be an institutional response with buy-in on the part of us who are providing care in those institutions, okay? And that's the point of those 3 bullet points. So multi-component interventions. If you want to look at a model, look at the delirium prevention strategies from the HELP program. And there is no evidence yet that you can make falls in the hospital and never event. What you're really going to be doing is minimize the frequency with which it happens and hopefully prevent injury, which is our major goal. So now I'm reaching the end of my presentation, and I hope to some extent you've recognized that falls have a huge impact on the health and well-being of Iowans, that falls are becoming a major public health problem and will get even worse as our population ages. I hope you understand the multi-factor nature of risk for falling and how that understanding requires a multifactorial approach to mitigating fall risk. And then recognize that across both people living at home and the institutions where people receive geriatric care, home care, nursing home care, acute hospital care, there are strategies that we as caregivers can apply to minimize the risk of falling and associated injury. So that, I think, is this last slide. They hurt people. The evidence is best for those living in the community, but it also supports benefit in nursing homes and hospitals. Carefully studied strategies will have an impact between 10 and 20%. And so that's a challenge for those of us who aren't involved in carefully studied strategies. And then interdisciplinary interventions appear to be the best way to go. If you're looking for additional resources, these are all available online. So the CDC has a major initiative in fall prevention, especially useful for communities. In Johnson County, we have something called the Sure Steps Initiative, where we've built a community project to reduce fall risk around the Centers for Disease Control initiatives. I'm a geriatrician. I like what the geriatricians have to say about fall prevention. And if you're interested, you can get their guideline online. If you work in a nursing home and you want something very specific for the nursing home environment, the American Medical Directors has a nice clinical practice guideline. And for those of you in the hospital, one useful strategy would be the Hospital Elder Life Program, which is based on the work of Sharon Inouye at Yale New Haven Hospital and delirium prevention. So those can be places to start or to build on your knowledge. Any questions? Yes?
Can you speak to the high-dose 50,000 unit vitamin D and the risk of falls?
Yes. So I think it was 500,000 units once a year increased the risk of falling down. Okay? So there was a study done. My recollection was it was 500,000 units. The idea was to do a once-a-year intervention to impact fall risk. And what in fact happened was people experienced a higher rate of falling after that particular intervention, which was in a nicely done trial, randomized controlled double-blind fashion. It creates an interesting tension between should we give people high doses prophylactically, so this is not about treating vitamin D deficiency. Should we be giving high doses periodically, say 50,000 units every 2 weeks, versus daily doses, 800 to 1,000 units every day? And I think that's a reasonable tension. It has made me be much more wary of resuscitation of vitamin D. So in my particular practice, I have moved away, and this is my approach, I think, but it's rooted in this observation. I have moved away from checking vitamin D levels and resuscitating with high doses. I have moved to a strategy of encouraging and prescribing more higher doses of daily vitamin D supplementation. If you give a person 4,000 international units of vitamin D a day, essentially there's a 99% chance that they will have a vitamin D level that's over 70 nanomoles per liter, okay? So just statistically, it moves them into this range where they're on that right side of that curve that we saw with the Institute of Medicine. Now that's how some of my colleagues are doing it. I've not moved that far from the Institute of Medicine. I'm asking people to do 1,000 to 2,000 units a day. That actually statistically moves them into a realm where you'll move them up nicely in terms of their vitamin D concentrations. And I think that helps me feel better about avoiding this observation that high doses in single doses might in fact make things worse. Was that useful?
Yeah.
Okay. So
So 50,000 50,000 units causes falls stuff out there.
Yeah, no, so high dose, single dose dosing of vitamin D has clearly some evidence that suggests that it increases the risk. And nobody really understands why. There's some thought it's doing something in the muscle that temporarily makes you weaker, and that's mitigated over time. But I am moving away from high dose resuscitation based on that literature. Any other questions? Yes.
Just an observation of the complexity of solutions. My mother was in a nursing home for 3 months in rehab, and during the time they installed a light in the hallway next to her door, which she could see 24 hours a day. And I was thinking, apparently it was some sort of regulation that had been required, maybe by Medicare, but I'm wondering, solutions are complex because the light obviously might detract from a person's ability to fall asleep, as you mentioned, and also there have been some studies that darkness at night improves healing and increases the melatonin production in your brain. So just installing a light 24 hours a day could have a detrimental effect, even though it might prevent some people from stumbling during the night to go to the bathroom. So these solutions have to be
I would
complex.
agree with you that it's very complicated, which is part of why I think people find it intimidating. Helping people sleep at night actually ends up being a very important strategy. So putting a light in a place that impairs a person's ability to sleep at night would be counterproductive. Lighting a pathway to a bathroom as part of an overall home hazard mitigation strategy. So if you bring an occupational therapist into the house, for instance, and they say, change this, 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 and this, and it includes lighting the pathway to the bathroom, we know that helps, okay? Whether that individual light or not helps gets a little bit debatable because nobody's done a trial to look at what happens if you put a light in the hallway. But as part of a multi-home hazard approach, that is helpful. So yes, it's complicated. The medication part illustrates the complexity of it. So people are prescribed medications by licensed prescribers who've gone through a great deal of education and training to try to do this well. And yet you still encounter circumstances where people are getting medications that may not be in their best interest in terms of falls. And so a lot of judgment comes into play about dosing, about need. There is a body of literature about taking away medications and what goes wrong when you take away medications, which is why, in my mind, part of the message here is that it needs to be holistic. One of the challenges to fall consultations is that they come in, they make these recommendations, they leave, and then nothing ever happens. I mean, it has to be part of a more holistic, comprehensive strategy, which is why the interdisciplinary nature is so important, okay? And why, if you look at this in terms of where it works and where it doesn't work, it works pretty well in people who have set their practices up to make it happen, and then work with others to get it done. So, and that's a tough task. So for instance, just to illustrate, my practice, everybody who comes into my geriatrics practice has their orthostatic blood pressure measurement done by the intake MA. They check their blood pressure sitting down, then they stand them up for 2 minutes, and they check their blood pressure standing up. And when I go to my internal medicine practice at the university, I can't get that done for the life of me. So in our geriatric practice, we have set up a strategy where no matter what happens, we know whether that person has orthostatic hypotension or not. And we have that information at our fingertips. We set that up ahead of time. Everybody gets asked about falls. Everybody who falls gets somebody to look at them walk. And that can be hard to do if you don't set your practice up to be that way. because it is complicated. Yes, in the back.
Yeah. Could you comment on the Beers list of medication?
Yeah, I'd love to. So the question is about the Beers list. So do you have a specific thing you want me to address with it? Okay, so the Beers list is a very interesting product that's available. It was published years ago. I was probably still in my residency by a geriatrician at UCLA by the name of Mark Beers. So that's how it gets its name, Mark Beers. And Mark Beers was interested in how we prescribe to older people, and he got with a group of experts and made a list of drugs that most experts would say you should not prescribe this in frail older people. It's gone through 3 revisions. One was done in the around the turn of the century, okay? And then another one was just completed this year. And it's a very useful tool. You can't use it dogmatically, but I think it can be very useful in terms of a series of guiding principles. And so having a healthy respect for tricyclic antidepressants and heavily anticholinergic drugs is a very healthy perspective that you can get if you look at the Beers list and really try to integrate what it has to say into your prescribing. And then the question is, so once you integrate that, is there a payoff? And again, I think if you do it as a practice style, okay, there's a payback. So if you take it to heart, I don't think old people should take Benadryl as a sleeping pill, okay? Just take that to heart. Take that for granted. You'll have patients, you'll say, don't take your Tylenol PM, and they'll say, forget it, I'm gonna take my Tylenol PM. But if you do that for every one of them, don't use Tylenol PM, and then some of them start to believe it, okay, I'll stop my Tylenol PM, they will be stopping it, and they will use less of it. They'll be less prone to problems with balance. They'll be less prone to delirium. And the big impact for Sharon Inouye was look at how she reduced the use of Benadryl at Yale New Haven Hospital, diphenhydramine, for sleep aid. And you all of a sudden go, oh my God, this may be why people don't get delirious. So I think knowing the Beers list, and it was published last month in the Journal American Geriatric Society. I think that's it. And if you go to the American Geriatric Society website, I think you can download it for free. Yes? For opioids and fall risk? Yeah, so opioids are, is that your question? So most of the literature on opioids does support the notion that it impairs balance, makes people sleepy, and increases the risk of falls. There are a few studies in the palliative care literature that suggest otherwise. And what most of this other literature comes from Mount Sinai Hospital in New York. And what they found was many people in the hospital are moving about their rooms because they're uncomfortable. And if you treat their pain effectively, they're less restless, they're less prone to delirium, and they move better. So it's a double-edged sword. I think used appropriately to treat pain, reduce pain-associated delirium, it could actually reduce one's risk of falling down. But I think in bulk, its use for, say, chronic pain disorders, it probably increases the risk of falling down. I use a lot of opioids. I think this is another one of those challenging circumstances where you have to try to use your judgment to help the patient balance pain relief versus the adverse effects that include increased risk of falling down. Any other questions? Well, thank you for your time. Thank you for spending your lunch with me. And thank you for having me to Ames.